Good morning, everyone. In one of the previous presentations, we saw most of the multimodal imaging findings in choroidal osteoma. What I'm going to talk about is more of a longitudinal study discussing how it grows, increases in size, or decreases, which gave us some clue about the deossification dynamics and the natural history. As you all know, it's a benign ossifying tumor which can increase or decrease in size. And there have been papers in the past, mostly by the Shields group, which talk about the long-term follow-up and the predictive factors. But most of these studies are from the pre-OCT era. And in subsequent papers on multimodal imaging in choroidal osteoma, the definitions of certain aspects like deossification is very unclear. So that is why we aim to analyze the multimodal imaging findings and the longitudinal changes and try to define some of these aspects properly. So this was a retrospective observational study of all cases of osteoma from 2012 to 2024, and we included most of the demographic findings and imaging findings. The first term we tried to define was deossification choroidal atrophy, which is kind of an end stage of deossification process because it's kind of a process, so it's difficult to measure. So we took the end stage, and it was defined by absence of osteomal lesion with visible choroidal vessels and thinning of choroid on OCT. Next, we tried to define RP atrophy, that was yellowish white discoloration seen as hypoautofluorescent area on FAF and transmission defect on OCT with or without deossification. From almost 14,000 files we screened, we came to around 100 eyes of 80 patients, making it one of the largest series ever reported of choroidal osteoma. Coming to the results, most of the patients were females and had unilateral involvement, but we did not find any systemic associations in any patients. So this is a case of uncomplicated choroidal osteoma. We can see that it looks kind of mildly hyperautofluorescent on autofluorescent imaging without any CNVM or deossification. We saw deossification choroidal atrophy in almost 38% of eyes and RP atrophy in 82.6% of eyes. Now, initially we thought there was some kind of age relation in these changes, but as you can see in this graph, RP atrophy tend to appear almost a decade before deossification. But when we did a multivariate regression analysis, we found that it was the total area of the choroidal osteoma that was more predictive of deossification and RP atrophy. Coming to the longitudinal changes, we saw an increase in the total lesion size, an increase in ossified area and the deossified area. Now something was odd. Increase in one should have been accompanied by a decrease in another. But we could see this because of cases like this, where there was an increase in deossification in one of the poles and an increase in the osteoma lesion from another pole. We also found these hyperreflective cavitations that tend to appear during the process of deossification. As you can see in this image, the osteoma size is decreasing with increase in cavitations. We could also see that in eyes which are having increase in osteoma thickness on OCT, most of these patients had SRF development without CNVM formation, as we had previously seen, and it was statistically significant. So coming to, based on all these findings, we could reach three clinical subtypes. One was osteoma without RP atrophy or deossification, one was osteoma with RP atrophy without deossification, and osteoma with RP atrophy and deossification. And if you look closely in these eyes, you can see all of these three zones coexisting, and you can confirm it using OCT. Just to conclude, deossification process and osteoma growth can coexist. The higher total area of baseline at baseline can predispose to faster deossification, and an increase in osteoma thickness and size is associated with SRF development without CNVM. Thank you.
What type of OCT is generally recommended in such type of cases?
Sorry?
What type of, there is a different type of OCT. What
Yes.
type of OCT is
A
generally?
swept source OCT will be best because a swept source OCT will be best because it has the maximum depth penetration and gives us almost the extent of the lesion.
And what about NG-OCT?
Angio-OCT, it cannot detect the flow or the extent of the osteoma, but it can tell you about the choricapillary flow. I think the next we have another presentation on it. In most of the cases, we have seen that this flow, the choricapillary flow, is well preserved in these cases.
Okay, so generally normal OCT is maybe an injustice for the patient.
OCT
so either NG-OCT or that one is very good. Very good. Okay.